Hello, my name is Susanna Muehlschlegel. I was asked to give a brief overview over moderate to severe TBI, so here we go. These are some updated numbers, but TBI remains a public health problem in the US and worldwide. So annually, almost 2 million Americans still sustain a TBI. And as you can see, in 2019 and 2020, nearly 225,000 patients were hospitalized with this, and the majority of those were patients with moderate to severe TBI, defined as GCS 3 to 12, and almost 64,000 died. And the healthcare costs in the US alone are extremely high because this is a pretty bad disease that keeps you in the hospital for a long time and disabled even longer. It's a male predominant disease. This is thought to be due to behavior. This is, as you can see, fairly old data up until 2010, but this really hasn't changed recently. When you look at causes by age group, falls here in the red are most common in the elderly, while in the very young, so pediatrics and toddlers, assault, often non-accidentally head trauma, are the most common ones. And as the children age, become teenagers and drivers, it is motor vehicle accidents. And then here also rising across adulthood are self-inflicted injuries. TBI is a very heterogeneous disease, making it very difficult to predict. As you can see here, patients can have an epidural hematoma, subarachnoid hemorrhage with skull fractures, a subdural hematoma, penetrating brain injuries such as gunshot wounds, subarachnoid hemorrhage, diffuse axonal injury, also more skull fractures, and they can have all sorts of combination of these injuries. When we treat patients with TBI in the ICU, our main rationale for doing so is the prevention of secondary brain injuries. We can't prevent the primary injury because that's already occurred. But the prevention of secondary brain injuries really begins immediately after trauma. It can be microscopic, for example, from hypoxemia, or macroscopic because of a large hematoma. It really determines the patient's outcome and can be prevented and controlled as much as possible. The most common examples of secondary brain injury include low blood pressure and low blood oxygen. For example, data has shown that any blood pressure less than 90 millimeters can occur in over a third of patients and really increases your mortality significantly. As you can see, a single blood pressure reading of less than 90 in the field or in the ER can increase your mortality from 34 to 75% and also increase your poor outcome. Similarly, with hypoxemia, any reading of a PaO2 of less than 60 or an oxygen saturation less than 90 also increases your mortality to more than double. As I've mentioned before, there can be diffuse mechanisms of injury, very focal disease, and here again some examples. Things that I didn't show before are contusions or combinations of contusions and subdural hematomas, global edema. This often happens when hypoxemia was the case, traumatic subarachnoid hemorrhage. So what we do to prevent secondary injury is stabilize them in the field, often from the cardiopulmonary standpoint. So we want to avoid hypotension, hypoxemia, as well as hyper or hypoventilation. Based on the most recently revised 2016 Brain Trauma Foundations, these are kind of the thresholds we want to avoid. And hypotension can be a marker of severe blood loss, but it can also be in spinal cord injury, cardiac tamponade, tension pneumothorax, and again, a single pre-hospital event of blood pressure less than 90 can double your TBI mortality rate. There are now new blood pressure recommendations, so not just greater than 90, but actually greater than 110 for anyone between 15 and 49 and greater than 70. There's the strange value of greater than 100 for patients between 50 and 69. This is really based on available data, but I usually say the rule of thumb should be greater than 110. We also want to prevent hypoxemia. So again, a single pre-hospital event of an O2 saturation of less than 90 can increase in a 50% mortality rate. The combination of hypotension and hypoxemia is particularly poor. So we want to secure the airway and don't waste time. So if the airway cannot be placed quickly, mask ventilation or LMA is preferred over wasting time to secure the airway. A word about hyperventilation. This is what can happen when you hyperventilate. So here on the left under A, we have an end-tidal CO2. So with hyperventilation, that drops as expected. But here on top is the brain tissue oxygen. So Lycox values. You can see through vasoconstriction, there is a drop in the O2 saturation locally in the brain tissue. So essentially, hyperventilation can lead to local brain hypoxemia, which is why we want to avoid it. The reverse, hypoventilation, might lead to an increase in the PbO2, but the problem is that it leads to vasodilation and ICP elevation. So that's the reason why we also want to avoid that. So the new recommendations about ventilation are that we want to prevent prophylactic and prolonged hyperventilation. It's okay to use it briefly, but to avoid it in the first 24 hours. We want to correct coagulopathy. Here's a list of all the new things that we see. So especially the new direct oral anticoagulants can be reversed. So rivaroxaban, apixaban, low molecular weight heparin, through charcoal if the last oral dose was less than 8 hours, but then also with PCC. The dabigatran is a little bit different. We do have an antidote for that, when that's also dialyzable, so emergent dialysis can be considered. Per ENLS, to place an ICP monitor in EVD and INR of 1.6 or less is considered safe, but I've seen our local neurosurgeons usually want an INR of 1.4, sometimes even lower than that. Platelets should be over 100,000 when a procedure is planned. And the reason why we want to correct coagulopathy is because contusions or subdurals or any lesions in the brain can grow, as well as hemorrhagic shock will be very difficult to reverse. So here's an example of where the frontal contusions in the brain can blossom from one day to the next. The indications for ICP monitoring have been updated as well. So it's recommended for patients with a low GCS and an abnormal CT. But sometimes it can also be indicated when the CT is normal, but if 2 or more of these 3 things are present. It can be an EVD, it can be an intraparenchymal monitor. The advantage of an EVD is that it can measure and treat, but sometimes it can be difficult to place because it's a blind procedure and the ventricles can be compressed or shifted. The Brain Trauma Foundation guidelines recommend CSF drainage whenever possible, because and to also keep the EVD open, as it is more effectively than intermittently opening it. But again, that is a little bit up to the surgeon's preference. The thresholds for ICP and CBP treatments have also changed. So per the most recent Brain Trauma Foundation guidelines, we should treat ICPs when they're over 22, meaning 23 or more, and CPP should be kept between 60 and 70. As I mentioned before in another talk, is that we now believe that this should be individualized, and we often try to figure this out with the help of a Lycox monitor, although we don't have that much data yet to really know what is the right way of treating CPP. What we do know is that an ICP threshold of less than 20 is no longer used. That is based on a clinical trial published in 2012 called the Best Trip trial. And this trial really showed that an ICP threshold of less than 20 isn't right for all patients. This is a trial that was done in Bolivia, not the United States, because it compared 2 groups. Severe TBI patients, they all had an EVD placed, but some had the ICP transduced, and a threshold of 20 was used to treat it. The others also had an EVD, but the ICP was not transduced. It was just used to drain CSF, and a clinical and radiological examination schedule was instituted. And what this trial showed that there was no difference between the groups, neither early nor late. So here in the little inlet, you can see through day 14, so the ICP monitoring group or the clinical and examination group, there was no difference between the two in terms of outcome and survival. There's also neuropsych testing done up until 6 months later, and there was again no difference. And you can see here that the p-value showed that there's no difference between the two groups. Some people have argued that, well, that means we shouldn't place ICP monitors, but that's really not what this trial showed. The authors very vigilantly argued that that's not what the trial showed. It really just showed that the threshold to treat at 20 doesn't seem to make a difference. We treat with seizure prophylaxis for the first 7 days, and this is based on an old trial, also published in the New England Journal of Medicine in 1990, that used phenytoin for the prevention of early post-traumatic seizures up until day 7. And you can see here's the proportion of patients with seizures, is that the phenytoin group had a much, much lower risk of post-traumatic seizures early on in the first week compared to placebo. Here in numbers, so the phenytoin group had a 3.6% chance and the placebo group 14% chance of developing early post-traumatic seizures. Now, we usually stop seizure prevention at day 7 because seizure meds do have side effects, especially cognitive recovery can be slow. And we don't have any data that it prevents late post-traumatic seizures. In fact, there's the thought that seizure meds don't make any difference. And so based on this trial, we usually stop seizure meds at day 7. Dissections can occur, and here is a list of indications as to when we monitor or obtain a CT angiogram, such as penetrating injuries, fractures across the venous sinus, fractures of the petrous bone, just because there's a lot of holes through which arteries can run, C-spine injuries, facial fractures, any nerve deficit not explained by head CT, and any anterior neck injuries, such as hanging or a seatbelt sign. I'll show you a picture of that. This is what a seatbelt sign might look for. On imaging, we can see dissections either on the CTA, sometimes on the MRA, and if we don't treat it right, we can have additional ischemic strokes resulting from the dissection. The vertebral artery is at risk, as well as the carotid artery, which is what's shown here. You can see here a dissection of the carotid artery that can lead to further strokes. We usually treat with aspirin as the preventative treatment, not with heparin, just because many times they have lesions on the brain that can bleed easily. And in the primary stroke literature, aspirin has the same effect as anticoagulation in terms of preventing strokes after dissection. 2 trials have addressed the need for surgical decompression or hemicraniectomy in TBI, and I'll show you those real quick. The DECRA trial, published in 2011, used a decompressive craniectomy in patients with ICP greater than 20, lasting for 15 minutes or more, but it was very, very early in the disease. Within a 1-hour period, despite first-tier treatments such as ventilation, sedation, osmotherapy, and then very quickly they moved to hemicraniectomy. This DECRA trial showed that there was a larger proportion of patients in the surgical group with poor outcome. Here is kind of in red, the standard, versus in green here, the decompressive craniectomy. And the higher the Glasgow outcome scale, the better the outcome. They dichotomized at 4, meaning one is dead, but between 1 and 4 is poor outcome, and between 5 and 8 is good outcome. And you can see this is the proportion of poor outcome was larger in the surgical group. And so based on that, the early decompression is not performed. The surgical group had some better outcomes in ISP control, fewer medical interventions, shorter length of stay in ventilation, but the clinical outcome at 6 months was worse, and therefore, based on DECRA, early decompression is not recommended. There were some thoughts as to why that might be. Some people reasoned maybe surgical technique, but most people believe that it was a very short period of ICP elevation and that people went to surgery way too fast. And there's also some other thoughts about the cranioplasty that happened later. Rescue ICP was another trial published 5 years later in 2016, but they did something else. They waited much longer to take patients for hemicraniectomy, and they really only took them when there was refractory ICP elevation of more than 25 for up to 12 hours, despite stage 1 and 2 stage 2 measures, which really reflects more of what we do in reality. We don't take people early. We give them tier 1 and 2 measures, and only if right before barbiturate use did they go for hemicraniectomy. Interestingly, in this trial, the surgical group had better outcomes. However, here is the big caveat. Where unfavorable and favorable is dichotomized was different between the two groups. So as you may remember, in DECRA, it was 1 to 4 that was considered poor outcome, while in Rescue ICP, it was 1 to 3, and the outcome group of 4, which is the lower moderate disability, was counted towards good outcome. And there was a lot of debate in the literature as to whether this difference in dichotomization really made the difference. So here's a blog that showed the difference. So here in red is the Rescue ICP dichotomy. And so you can see they counted 1, 2, and 3 as poor outcomes. So death, vegetative state, and lower severe disability really depended on many others. And as you can see, there is a difference between surgical and medical group, and that the surgical group did better. If you use the conventional dichotomy, where most trials dichotomized and also where DECRA dichotomized, which is 1, 2, 3, and 4 to be included in the poor outcome group, you can see there would not have been any difference. And so similar to DECRA, the surgery would not have been favorable. However, the authors argue that the severity of the injury in severe TBI justifies this threshold, and it was pre-specified. It's not that they changed it. The authors also say it's not for us, the clinicians or the researchers, to decide whether a given degree of disability is acceptable. It should be really shown to the surrogates when they make a decision. And so, we don't do this often enough to really show them the difference between groups in shared decision making, but that's what they're suggesting should be done. And so this is why for Rescue ICP, we do consider hemicraniectomy, but when the surgeons obtain consent, they will say very clearly that it will only prevent very, very severe disability or mortality, but it will not change the, moderate disability or mild disability. So with that, I'll stop here for severe TBI. As always, you can contact me if you have any questions. Thank you.